All right, our next section is uterine rupture. This is a rare event. This is painful bleeding. Here we have a ruptured uterus. This is the myometrium. Here is the placenta and the blood which is pouring out. This was from the site of a previous classical uterine incision vertically on the skin. Here's our case. A 27-year-old gravida 2 para 1 comes to the labor and delivery for evaluation for regular contractions at 34 weeks, so she's preterm. Previous delivery was emergency cesarean at 32 weeks due to hemorrhage from a placenta previa. Now, the incision that they made on the uterus was a classical uterine incision, vertically, not in the lower segment, and the reason they didn't do a lower uterine segment was because there were varicosities down there. So her previous incision was a classical, up and down. A classical uterine incision is 10 times more likely to rupture than a lower segment incision. So as you're examining her, and she's having contractions at 34 weeks with a previous vertical classical uterine incision, she suddenly complains of abdominal pain, there is profuse vaginal bleeding, fetal bradycardia, and inability to pick up uterine contractions. Now the next sentence is really important. The fetal head, which formerly was at -1 station, now remember, station is an expression of how far down the head has come. The station was at -1, and all of a sudden, it went back up. Hey, listen, the fetal head does not go up normally. It keeps coming down. If suddenly it goes up, associated with pain and with bleeding, that is uterine rupture. And the reason the head has gone up is because the fetus that used to be in the uterus is now extruded out of the uterine cavity. Character of the bleeding, painful or painless. Painful bleeding. Placental location, doesn't matter. It's usually normal. It's not in the lower segment. That's not part of the pathophysiology at all. The pathophysiology is complete laceration of the uterine wall. Complete laceration of the uterine wall. Some time ago, I was on call at the hospital, and the emergency department called and said, we want you to come down because we're bringing a woman in who was in a motor vehicle accident. She's 37 weeks. She was T-boned. Car hit her from the side. They had to cut her out of the car with these big jaws of life. She's got a fractured femur. She's got injuries to her neck. And we want to know how the baby's doing. So we went down with an ultrasound machine. So she comes in, and the first thing, of course, the emergency department folks, they descend on her. They want to make sure the mother is stable. They want to make sure there are spine precautions, that the neck is okay, and they check all that. Once the mom is stable, then they say, okay, you guys go for it. So we go with our ultrasound. And the first thing we look for is, where's the fetal head? Okay, the fetal head is down near the pelvis. Then we look for the spine. Anterior to the fetal spine, what should we see? Heart beating, right? Guess what? No heart beating. Baby's dead. Okay, now put the clinical situation together. Baby's dead, motor vehicle accident. What's the most likely explanation? Abruptio placenta. A concealed abruption. Well, she's got orthopedic problem, which is going to require operating room care. She's got to go to the OR, and there's nothing that we can really do. She's stable. So she goes to the operating room. The orthopods, they fix her femur, and up she goes to the ICU. In the ICU, her hemoglobin starts dropping. Femur's fine, but the hemoglobin is dropping. And what's our suspicion? A concealed abruption. We're going to have to open her up because she's going to be becoming hypotensive. So we opened her up, opened up the abdominal wall, opened up the peritoneum, and what do you think we saw? This was a uterine rupture. The fetus was extruded entirely into the uterine cavity. This was not a concealed abruption, which we thought it was. Complete laceration of the uterine wall. Now, the uterine wall can get very thin from a previous cesarean. I've seen where it is so thin that you can see the fetal hair through the thinned lower segment. That's not what we're talking about. We're talking about complete laceration here. The diagnostic triad, and this you should fix into your brain: painful bleeding, lost fetal heart tones, and the fetal head goes up. You have a loss of station. That's consistent with uterine rupture, particularly in the presence of a previous uterine scar. Risk factors, well, I just mentioned this. A uterine scar, either a classical cesarean or a previous myomectomy. Excessive oxytocin would be unlikely. There is only one management: get the baby out, usually it's going to be dead, and repair the uterus. Fortunately, on this patient, we were able to repair the uterus. The only time you do a hysterectomy is if you cannot stop the bleeding. Of course, complications, maternal and fetal death, are possibilities, and we want to avoid that. This is looking at the uterus, and we're dividing the uterus into the upper segment, which is here, the lower segment, which is here. Remember, contractions occur in the upper uterine segment. The lower uterine segment stretches. So the most likely place for uterine rupture to occur is in the upper segment, not the lower segment. If there is a classical uterine incision, and if she should labor, the likelihood of rupture is 5%. Now that's not high, 1 in 20, but it's still significant. If you have a lower uterine segment incision, most commonly it will be a transverse one, the risk of rupture is 10 times lower, only 0.5%. So that's why we do not consider it safe for a patient with a previous classical cesarean to labor. If you would remember, painful late trimester bleeding, loss of fetal heart tracing, inability to identify uterine contractions, and particularly if you have loss of station of the fetal head, that is consistent with a uterine rupture. And that brings us to the end of this segment, uterine rupture.